Hello everyone and welcome to our module on non-Hodgkin lymphoma. Non-Hodgkin lymphomas are a diverse group of lymphocyte malignancies, and as we'll see later in this video, there are many different subtypes with different clinical patterns. Often non-Hodgkin lymphomas present as lymphadenopathy and an enlarged lymph node like shown in this picture, but you should be aware that non-Hodgkin lymphomas also commonly develop in extranodal locations. This means outside the lymph nodes, so in locations like the skin, the GI tract, or the salivary glands. It's uncommon for Hodgkin lymphoma to have extranodal disease, but it's common for Hodgkin lymphoma to do this. Lymphomas can arise from B cells and T cells, and so the malignant cells in lymphoma are often characterized by their surface antigens, and it's easier to understand how this is done if you know what the normal lymphocyte antigens are that are found on T cells and B cells. So normally on T cells, the antigens you find on the surface have low numbers like CD1 through CD8. In contrast, B cells usually have surface antigens with higher numbers. This can include CD10, which is present in B cells when they're developing, and then more mature B cells usually have higher numbers like CD19 through CD23. And then finally, because B cells can produce antibodies and immunoglobulins, you often find surface immunoglobulin present on the surface of B cells. And so if you know the information on this slide, it'll be very helpful later when we talk about characterizing the malignant cells of lymphomas. So in terms of classification, non-Hodgkin lymphomas are B and T cell malignancies. Most of them are B cell disorders, but there are some T cell lymphomas as well that we'll talk about in this video. And in most cases, the malignant cells grow in the lymph node and completely obliterate the lymph node architecture and take over the lymph node, and this is what causes the enlarged lymph nodes that are part of lymphoma. There are more than 24 subtypes according to the WHO, and they're classified based on a number of features. One way is as B cell versus T cell, and this is often done using those surface antigens we just talked about. They're also classified based on the cell size of the malignant cells, whether they're small or large, and then also on the histologic appearance, the expression of certain markers. This is called the immunophenotype of the malignant cells, and finally based on genetics. As I said, B cell lymphomas are the more common type of non-Hodgkin lymphoma, and you can split the B cell lymphomas into two groups, those that have aggressive growth and those that have indolent or slower growth. So the ones with aggressive growth grow rapidly and B symptoms are common. This includes the three lymphomas shown here, which we'll talk about in this video. The indolent B cell lymphomas are these three shown here. They tend to have a slower growth and a slower onset of symptoms. And then finally in this video, we'll talk about two T cell non-Hodgkin lymphomas, which are these two disorders shown here. Now one more thing before we get into specific subtypes of non-Hodgkin lymphoma. Shown on the left here is a cartoon of the structure of a lymph node, and lymph nodes are made up of these circular areas called follicles that contain lymphocytes. You can see actual follicles in the image on the right. I'm circling one with my pen here. So as we will see, there's one type of non-Hodgkin lymphoma called follicular lymphoma because it involves growth of the follicles. Also, surrounding the follicles is an area of cells called the mantle zone, and so one form of lymphoma is called a mantle cell lymphoma. And then when there's inflammation, the follicles begin to grow and enlarge. That's what causes enlarged lymph nodes during inflammation. And the zone where the follicles enlarge and grow over is called the marginal zone. And so we will also see later that there's one subtype of non-Hodgkin lymphoma called marginal zone lymphoma. Okay, our first form of non-Hodgkin lymphoma that we'll discuss is called diffuse large B-cell lymphoma, and this is the most common type of non-Hodgkin lymphoma. It's one of the aggressive forms of B-cell lymphoma that we talked about a few slides ago. It typically displays rapid growth. It has the word B-cell in its name because it's a B-cell malignancy. The malignant cells in this lymphoma express B-cell markers like CD19 and CD20. Most of the cells also express surface immunoglobulin. In diffuse large B-cell lymphoma, the malignant cells obliterate the follicles, so you lose that normal lymph node architecture and just see a large collection of cells in the node. In general, this is a disorder of older patients. The median age at presentation is 64 years. And you should also be aware that this occurs in patients with HIV, and it's an AIDS-defining malignancy. When the immune system is severely compromised, it makes this form of lymphoma more likely. And the treatment of diffuse large B-cell lymphoma is an advanced topic, but you should be aware that the treatment often involves rituximab. This is a drug that is an anti-CD20 antibody, so it targets malignant B cells with CD20 on their surface. Okay, next let's talk about follicular lymphoma, which is one of the indolent forms of B-cell non-Hodgkin lymphomas. So this is also a B-cell malignancy, and the malignant cells usually express CD19 and CD20, as well as surface immunoglobulin. It's called follicular lymphoma because the malignant cells grow in follicles. So on biopsy, you see an image like you see on the screen here, where there are still follicles within the lymph node. The genetic hallmark of follicular lymphoma is a translocation of genetic material between chromosomes 14 and 18. This leads to overexpression of a gene called BCL2. BCL2 is a gene product that blocks apoptosis. It's called an antagonist of apoptosis. Apoptosis is a programmed form of cell death that lymphocytes should undergo so that they die and don't grow uncontrollably. But when there's overexpression of BCL2, the lymphocytes grow and divide uncontrollably, and that's what leads to follicular lymphoma. And so from a clinical point of view, detection of overexpression of BCL2 is used for the diagnosis of follicular lymphoma. Follicular lymphoma is also a disorder of older patients. The median age at diagnosis is 65 years. And as I said earlier, follicular lymphoma is one of the indolent forms of B-cell non-Hodgkin lymphoma. So it has an indolent course where it can wax and wane for years. Many patients with this condition have long-standing lymphadenopathy, and not all patients require treatment, and in general, follicular lymphoma is difficult to cure. And one thing to be aware of is that patients who have follicular lymphoma for a long time can see their disease transform into diffuse large B-cell lymphoma. Remember, both follicular lymphoma and diffuse large B-cell lymphoma are B-cell non-Hodgkin lymphomas. So follicular lymphoma, which is indolent, can transform into diffuse large B-cell lymphoma, which is more aggressive, and when this happens, this generally carries a poor prognosis. When you biopsy a lymph node and you identify enlarged follicles, that could be a case of follicular lymphoma, but it also could simply be reactive lymphadenopathy, because when there's infection, this leads to growth of the lymphocytes in the follicles. That's why your lymph nodes become enlarged during infection. So one thing pathologists do when they examine biopsy specimens is try to distinguish lymphoma from reactive lymphadenopathy. Some of the things they look for are, first of all, in reactive lymphadenopathy, there's no BCL2 overexpression. Also, when there's infection, B cells are rapidly growing, and some of them will actually die, and this will cause the formation of debris in the lymph nodes, and that will draw in macrophages. So the presence of macrophages also suggests reactive lymphadenopathy. So I've summarized on this table on the slide here some of the ways pathologists distinguish lymphoma from reactive lymphadenopathy. First of all, in lymphoma, the growing follicles tend to have a similar size and shape, whereas the size and shape are variable in reactive lymphadenopathy. In lymphoma, there's a relative absence of macrophages, whereas in reactive lymphadenopathy, you can see what are known as tingible body or debris-laden macrophages. And then finally, as we talked about earlier, in follicular lymphoma, there's strong staining for BCL2, whereas the staining is generally weak or negative in cases of reactive lymphadenopathy. Okay, our next form of non-Hodgkin lymphoma is mantle cell lymphoma. And as I talked about earlier, the mantle zone is a ring of lymphocytes that surrounds the germinal center of follicles in the lymph node. Mantle cell lymphoma is one of the aggressive B cell forms of non-Hodgkin lymphoma, and so because it derives from B cells, the malignant cells usually express CD19 and CD20, as well as surface immunoglobulin. And then a special thing about the cells of mantle cell lymphoma is that they usually express CD5. CD5 is normally a T cell marker, but it's found in certain B cells in the setting of malignancy. So the cells of mantle cell lymphoma are said to co-express CD20 and CD5, which means they co-express a typical B cell marker of CD20 as well as an unusual B cell marker of CD5. The median age at diagnosis is 68 years, and the median overall survival is 3 to 4 years. In general, mantle cell lymphoma has a poor prognosis, and again, it's one of the aggressive B cell non-Hodgkin lymphomas, along with diffuse large B cell lymphoma. In about 50 to 65% of cases of mantle cell lymphoma, the malignant cells have a translocation of genetic material between chromosomes 11 and 14. This leads to overexpression of the gene for cyclin D1. Cyclin D1 is a gene product that promotes cell growth and division, so when it's overexpressed, this leads to uncontrolled cell growth, and that's what leads to mantle cell lymphoma. And so in terms of diagnosis, positive staining of the malignant cells for cyclin D1 is one of the features that's used to identify cases of mantle cell lymphoma. Next, let's talk about the marginal zone lymphomas, which refers to a group of B-cell malignancies. And the thing you always want to remember about the term marginal zone is that that's the zone surrounding the follicles in the lymph nodes that grows and develops in the setting of inflammation. So these lymphomas are going to be associated with conditions where there's lots of inflammation and therefore growth of the marginal zone. That will sometimes lead to a malignancy involving those marginal zone B cells. Marginal zone lymphomas are often extranodal, so they tend to occur in places like the GI tract or the spleen. And as I said, they occur mostly in patients with chronic inflammatory disorders who have chronic growth of the marginal zone. So this is the type of lymphoma that can occur in the salivary glands in patients with Sjogren's syndrome. These can occur in the thyroid gland in patients that have Hashimoto's thyroiditis. It can also occur in the stomach in patients who have chronic infection with the bacteria H. pylori. When this happens, it's called a maltoma, and I talk about this in videos in the GI section, but a maltoma is just a variant of a marginal zone lymphoma. Small lymphocytic lymphoma is another B-cell subtype of non-Hodgkin lymphoma. In this condition, the malignant cells co-express CD20 and CD5, which is similar to the cells in mantle cell lymphoma that we talked about earlier. The distinguishing feature of SLL is that usually these cells are negative for cyclin D1, and as I said earlier, cyclin D1 is one of the major features of most cases of mantle cell lymphoma. You should also be aware that small lymphocytic lymphoma has the same malignant cells as chronic lymphocytic leukemia, which I talk about in another video. The only difference between SLL and CLL is the degree of lymphocytosis, meaning how high the white blood cell count gets. In small lymphocytic lymphoma, peripheral blood usually has a normal white cell count or only a very mild lymphocytosis. By definition, to meet the criteria for SLL, the peripheral lymphocyte count has to be less than 5,000. If it's above 5,000, then we call the condition chronic lymphocytic leukemia. Okay, next let's talk about Burkitt lymphoma, which is a highly aggressive B-cell form of non-Hodgkin's malignancy. Burkitt lymphoma is sort of famous for being a very aggressive and rapidly progressive type of lymphoma. The malignant cells derive from B cells, so they usually express CD19 and CD20, and most cells express surface immunoglobulin, just like many of the B-cell forms of non-Hodgkin lymphoma. Some key distinctions of Burkitt lymphoma from other forms of non-Hodgkin lymphoma are first of all the starry sky morphology on microscopy. So this is an example on the screen here of what Burkitt lymphoma looks like under the microscope. First of all, notice that the cells have completely obliterated the normal follicular architecture of the lymph node. You can also see all these dark spots within the malignant cells. Those are chromosomes that are replicating. So this malignancy is highly aggressive, so there's lots of mitotic activity within the malignant cells as they replicate chromosomes. And then some of the malignant cells undergo apoptosis, and their remnants are eaten up by macrophages, and it creates these clearings within the malignancy that you can see. And so because it has these random sort of clearing spots within the malignancy, this is called the starry sky pattern of Burkitt lymphoma. And then beyond the classic appearance by microscopy of Burkitt lymphoma, some other key features are its association with Epstein-Barr virus and the C-Myc translocation. Epstein-Barr virus is the virus that causes infectious mononucleosis, and this virus infects B cells, and it can become a latent infection inside a B cell, and therefore it can potentially transform a B cell into a malignant cell of Burkitt lymphoma. And nearly all of the endemic forms of Burkitt lymphoma are associated with latent Epstein-Barr virus infection. Endemic Burkitt lymphoma occurs in Africa and New Guinea, and the endemic tumors express CD21 on their surface. CD21 is a B-cell marker, but it's also the receptor that the Epstein-Barr virus uses to gain entry into B cells. And then the C-Myc translocation is strongly associated with Burkitt lymphoma. C-Myc is a gene that's a cell growth promoter, and in many cases of Burkitt lymphoma, this gene gets translocated, so it sits close to immunoglobulin genes, which the B cells routinely express. So what happens is because of this translocation, as the B cells express their normal immunoglobulin genes, they end up also expressing C-Myc. And so this overexpression of C-Myc leads to uncontrolled cell growth. Burkitt lymphoma has a number of clinical forms. As I mentioned on the last slide, the endemic form is found in Africa and New Guinea, and almost all of these cases are associated with Epstein-Barr virus infection. In some regions of Africa and New Guinea, 30 to 50% of childhood cancer is due to Burkitt lymphoma. It usually occurs in children 4 to 7 years old, and it's more common in males compared to females. And it commonly presents as a mass in the face or mandible. This is a picture of a child with the endemic form of Burkitt lymphoma on the screen here, and you can see this mass growing in the jaw. There's also a sporadic form of Burkitt lymphoma. This is what occurs in the United States, and this is less commonly associated with Epstein-Barr virus infection. This also occurs in children, but it usually doesn't present as a face or a mandibular mass. Instead, it presents as an abdominal mass. Often it develops in the small intestine, in the ileocecum, or in the peritoneum. And then finally, there's an immunodeficiency related form of Burkitt lymphoma that, as the name implies, develops in patients with immunosuppression, and this form can have a variety of different clinical features. Okay, I'll finish this video by talking about some T-cell forms of lymphoma. In general, the T-cell forms of lymphoma are less common than the B-cell types. We'll start by talking about T-cell leukemia lymphoma, and it gets its name because it presents with T cells in the plasma, therefore it looks like a leukemia, but it also has features of a lymphoma. This is a malignancy involving CD4 positive T cells, and it occurs in patients who have infection with the virus HTLV1. This is an RNA virus that infects CD4 positive T cells, and when this happens, it can sometimes transform those cells into malignant cells. So as you can imagine, a key diagnostic test for this form of lymphoma is anti-HTLV1 antibodies. They are usually positive in patients who have this condition. In terms of clinical presentation, the patients who develop this condition are usually from an endemic HTLV1 region of the globe. There are a number of places where HTLV1 is common. Some of them include Japan, the Caribbean, and West Africa. You can also find it in northeastern Iran. It's also more prevalent in the southeastern United States. And then it's called leukemia lymphoma because patients present with an elevated lymphocyte count similar to leukemia. They have a lymphocytosis, but also lymphadenopathy similar to lymphomas. Beyond this, these patients often have skin lesions, so there's lots of T cells in our skin, so many T cell malignancies involve the skin. So patients with T cell leukemia lymphoma can develop skin ulcers and skin nodules or even a papular rash. It's also associated with lytic bone lesions, which can lead to high calcium, and this can make you think of multiple myeloma, but in multiple myeloma you don't see lymphocytosis, lymphadenopathy, and skin lesions. And then in general, T-cell leukemia lymphoma is usually rapidly progressive, and it's often fatal within a few months of diagnosis. I'll finish this video by talking about the cutaneous T-cell lymphomas. This refers to a number of disorders that involve malignant CD4 positive T cells. And these disorders present with skin lesions. As I said earlier, many T-cell malignancies involve the skin. There are various forms of cutaneous T-cell lymphomas caused by similar malignant cells. One of the more common forms is a localized skin disease called mycosis fungoides, but less commonly patients can develop a diffuse systemic disease involving malignant CD4 positive T cells, and this is called Sézary syndrome. Mycosis fungoides usually occurs in patients 50 to 60 years of age, and the skin lesions can have a number of different appearances. They can be patches or plaques or other types of skin growth. Usually they vary in size and shape and progress slowly. This is an example of what a lesion of mycosis fungoides can look like on the slide here. And one thing to be aware of is that this condition often mimics eczema or contact dermatitis. So in a patient with one of these conditions, especially if it's not responding appropriately to therapy, you often do a skin biopsy to rule out the diagnosis of a T-cell malignancy. And so the diagnosis of mycosis fungoides is made by skin biopsy. What you will see are neoplastic T cells in the epidermis and upper dermis. And these T cells have nuclei that look like the brain. They're called cerebriform nuclei. And I'll show you a picture of what this looks like in just a minute. So in mycosis fungoides, there's a localized malignancy of the skin caused by malignant T cells. In Sézary syndrome, similar T cells lead to a T cell lymphoma affecting the skin of the entire body. So this can lead to widespread erythema. The skin can potentially become bright red. This is a picture of a man with Sézary syndrome on the slide here. These patients also develop lymphadenopathy and an associated leukemia with malignant T cells in the blood. The malignant T cells in the blood are called Sézary cells. This is a picture of what one looks like on the slide here. Because their nucleus looks like the brain, it's called a multilobed cerebriform nucleus. And you can also see T cells that look like this in the epidermis and upper dermis of patients who have mycosis fungoides. And that concludes our module on non-Hodgkin lymphoma.